Hello friends, let's discuss an important topic very commonly tested in USMLE AMC and NEET. Myself, Dr. Kadir Stalin. So here comes this question. This question displays you a radiographic image, and the question asks the disease process responsible for this radiographic finding would most likely affect which of the following: cervical spine, lumbar spine, sacroiliac joint, or thoracic spine. Before answering this question, you should know what the disease are they talking about. So look into the x-ray. You can see several joint involvement, especially metacarpophalangeal joint and the proximal interphalangeal joints are very badly affected, and there is a symmetrical involvement. So symmetrical involvement, several joint involvement, hand joint or the small joint involvement, all these you can see the problem is affecting the wrist as well, and the distal radial joint is affected as well. So all this are pointing towards one diagnosis, nothing other than rheumatoid. So the diagnosis is rheumatoid arthritis. So the question now asks you, which part of the spine is most commonly affected with rheumatoid arthritis? The answer is cervical spine, especially the C1 and C2 are very commonly affected with the rheumatoid arthritis. So we all know rheumatoid arthritis is a chronic condition, and we should know that it is a systemic autoimmune disease. So it's not a disease of just a joint and the bone around the joint. It is a disease of synovium. It causes pannus formation. It can affect the ligament around the joint. It can affect the tendon around the joint. It can cause various soft tissue problems. It can affect even the cardiac system, like the pericardium can be involved. The valves can be affected. In the pulmonary system, it can affect the pleura. It can cause an interstitial lung disease. It can be associated with pneumoconiosis and things like that. So it's a systemic autoimmune disease. And why it is happening? It is because of a abnormal cell-mediated immune response, especially through IgM, and the cellular mediator is mononuclear cells. So mononuclear cells are the primary cellular mediator for the pathology. Coming on to the clinical feature, the patient usually it's a female predominant disease actually, and patient present to you with a pain, swelling, and morning stiffness. Some people say it's more than half an hour, and some people say it's more than 1 hour, and several small joint involvements is there, but classically in the hand, distal interphalangeal joint is spared. The commonly affected joints are the metacarpophalangeal joint and the proximal interphalangeal joint, but the distal interphalangeal joints are usually spared. It can be associated with the systemic symptoms, as I said you, and diseases, features like anemia can be there. So what kind of anemia? Usually it is a normocytic and normochromic anemia. And when it comes to the cervical spine involvement, it is associated with a atlantoaxial subluxation. It's still possible. And as I was explaining, it's a female predominant disease, and it is a middle-aged disease, usually at 35 to 55 age group. So middle-aged women are very commonly affected with this disease. So the criteria what I displayed here, this is not a diagnostic criteria, rather it is a classification criteria, which means of the seven features what I've displayed here, if the patient present to you with 4 or more, then you can classify them as a rheumatoid arthritis as according to this 1987 criteria. I remember this criteria as 6 yes and 1 R. So the first S is just stiffness, so stiffness more than 1 hour, and several joint involvement, by which I mean 3 or more joints, and small joint involvement, especially the hand joint, and symmetrical involvement, and swelling, by which I mean the subcutaneous nodule and the rheumatoid nodule, which is very pathognomic for rheumatoid, and it usually indicates a poor prognosis, and serological factors like rheumatoid factor positivity. So these are the 6 yes, and the last component of this criteria is the radiological parameter. So 6 yes and 1 R, that's how I remember this criteria. So of this 7, if a person is having 4 or more, then they are classified into rheumatoid arthritis group. But this criteria was later modified in the year 2010, and this criteria, what I displayed now, is having a more sensitivity and more specificity to diagnose rheumatoid arthritis. So, of this 10-point system, if someone is having 6 or more, then they are diagnosed to have rheumatoid arthritis, or classified to have a rheumatoid arthritis. So this picture from Harrison explains the distribution of rheumatoid arthritis in the small joint, especially in the hand. So as I was telling you, metacarpophalangeal joints are classically involved, and proximal interphalangeal joints are involved, but distal interphalangeal joints are usually spared in the rheumatoid arthritis. And wrist joint involvement is common, and distal radial nerve joint involvement is common. And I told it's not just a disease of a joint; it can affect the tendons, pulleys, and ligament. Okay, from this slide, one point I want you to remember is that distal interphalangeal joint is usually involved in OA and psoriatic arthritis and reactive, but not in rheumatoid. But still, you will get to see few deformities around the distal interphalangeal joint, like swan neck deformity and botanier deformity. Why it is happening? Is it entirely because of a problem in the joint, or problem around the tendon or the ligaments? Let's discuss about that bit later. So, disease, it can affect the tendon, and patient can present to you with decurrent tenosynovitis or other tendon tenosynovitis. Trigger finger, I told swan neck deformity, botanier deformity, we can talk about it a bit later. And Z-line deformity, the hand, as I was showing the arthritic mutilant x-ray at the beginning of this presentation. So the hand would have it can give a typical Z-shaped deformities, and because of the distal radial nerve joint involvement, patient can have a piano key movement between the radius and ulna. And in the knee joint, if the lateral components are involved, lateral column is involved, then the patient can present to you with a genu valgum. And if the medial component column is involved, then the patient can present to you with a genu varum. And if the person is having genu varum in one limb and genu valgum in other limb, that is called windswept deformity. I will show you the picture, don't worry. And coming on to the neck involvement, it can cause an adnectoaxial involvement, degeneration, and card compression, and things like that. So it's usually restricted to the cervical spine. Coming on to the swan neck deformity and botanier deformity. So please understand the extensor mechanism. The extensor mechanism is having what is called as a central slip and what is called as a lateral slip. Central slip crosses just the proximal interphalangeal joint and attaches to the middle phalanx, while the lateral slip crosses all the way the proximal interphalangeal joint and also the distal interphalangeal joint and attaches to the distal phalanx. So if the central slip is torn, okay, but the intact lateral slip, when the person is trying to cause an extension, can only bring extension in the distal interphalangeal joint because it is not attached to the middle phalanx. But since it is crossing the proximal interphalangeal joint, when it is trying to cause the extension at the distal interphalangeal joint, it will cause an abnormal flexion at the proximal interphalangeal joint. That is what called as a botanier deformity. That is an extension in the distal interphalangeal joint and flexion at the proximal interphalangeal joint. Right? So that is what called as a botanier deformity. But instead of a central slip tear, as in this case, if the lateral slips are gone, then there is no mechanism to bring an extension in the distal interphalangeal joint, but the intact central slip will bring an extension in the proximal interphalangeal joint. So what happens? A flexion in the distal interphalangeal joint will happen with an extension in the proximal interphalangeal joint. So that's what called as a swan neck deformity, right? So swan neck deformity is basically a problem of a lateral slip, while the botanier deformity is problem of a central tendon or a central slip, right? So I was telling you something like a windswept deformity. Look, in this case, the patient is having a genu valgum and the person is also having a genu varum on other limb. So that's varum and this is valgum. So if a same person is having a varum and valgus, then we call that as a windswept. Deformity. So windswept deformity. So windswept deformity in children, the potential cause is rickets, but in adults it is rheumatoid arthritis. Coming on to the systemic manifestation, I was telling you about the subcutaneous nodule. Other than that, this can be associated with diseases like Jorgen syndrome. So you know the Jorgen syndrome is associated with keratoconjunctivitis sicca. Sicca means dry. So the patient have a dry cornea and dry conjunctiva, and patient can have a scleritis as well. Rheumatoid arthritis is associated with scleritis. And coming on to the pulmonary problems, patient can have pleural issues. Patient can have pericardial issues. Um, Pericardial issues, and a patient can have valvular diseases like mitral regurgitation is very common. In pulmonary, it can cause an interstitial lung disease. It can be associated with Kaplan syndrome. You know, Kaplan syndrome is rheumatoid arthritis nodules along with that of pneumoconiosis. And in blood, you all know Felty syndrome. Felty syndrome is nothing but splenomegaly and neutropenia along with a rheumatoid nodule. And the rheumatoid is associated with vasculitis as well. So there are heaps of systemic manifestation in rheumatoid arthritis. Coming on to the radiological feature, in early rheumatoid arthritis, all you will be seeing is just a joint space narrowing as in here. But over time, when the patient develops a moderate rheumatoid arthritis, you will start seeing some erosion as well. And then if when you see subluxation, it already indicates it's a severe rheumatoid arthritis. And if the subluxation involves several joints, and if the joint looks mutilated, as I was explaining right at the beginning with the X-ray, or as in this case, that is what called as a terminal rheumatoid arthritis. So with the serological way to diagnose this is using a RA factor and anti-CCP. But remember, anti-CCP is of late considered more specific and more sensitive as well. More sensitive as well. Well, the RA factor is nothing but an IgM targeted against the FE, the fixed portion of the IgG, and it is usually elevated in 75 to 80% of patients with rheumatoid arthritis. And rheumatoid is associated with elevated ESR and elevated CRP as well. And coming on to management, that itself is like a potential big topic. It's a big pharmacology topic, the DMARDs and the classifications and things like that. So let's discuss the management of rheumatoid as a separate video with another question. Please feel free to like, comment, and share this video, and feel free to ask your questions in the comment section. Let me try my level best to answer your questions. Thank you.